All right, everyone, welcome. We might have a few more people jump on in a little bit. If I don't know you, my name is Whitney. I'm the program director at the Down Syndrome Partnership, and we're super excited to have Sean from the National Down Syndrome Society talking to us today about Medicaid and the changes that have happened from the recent bill that was passed, one big, beautiful bill. This recording will be recorded and sent out in an email with the PowerPoint after the presentation, and it will be available on our website as well if you need to watch it later. And I just ask that you please mute yourself during the presentation to help with background noise. All right, thanks so much, Sean. You can take it away.
Thank you, Whitney. Let me share my screen and I can pull up my presentation here. Can you all see that okay?
Yes.
All right. Well, hello, everyone. My name is Sean Feely. I am Director of Advocacy and Public Policy for the National Down Syndrome Society. First off, big thank you to the Down Syndrome Partnership for inviting me to speak today about a very important topic covering the recent changes to Medicaid that were made as part of the One Big Beautiful Bill Act, and then covering the potential impacts on the Down syndrome community, what we can expect in terms of timeline, but also opportunities for individuals to engage. As many of you know, this is an area where NDSS has been especially active around healthcare and Medicaid in particular. So really grateful to share information, resources today, and of course want to be a resource going forward. If there are questions you have that I don't get to today, um, feel free to always reach out to me, to us at NDSS. We want to be helpful to you all in the work you do. So I'll start off um, just with a little word about who NDSS is for those not familiar, who we are. So National Down Syndrome Society was founded in 1979 to empower individuals with Down syndrome and their families. And our work is focused on four main pillars: resources and support, research, advocacy and policy, and community engagement. As some of you may know, we recently announced a merger with LuMind IDSC Foundation, which is really going to bolster our research capacity looking in to different medical conditions, the biomedical space, and Alzheimer's. But our overarching mission is to create a world where individuals with Down syndrome thrive. Uh, Talking about Medicaid today, part of that, and part of that of making that world possible is access to quality healthcare and supports, including through Medicaid. Just a brief introduction to the NDSS policy and advocacy team. As I mentioned, I'm Sean Feely, Director of Advocacy and Public Policy. You all may have interacted before with other members of the team. Kevin Ryle, our Manager of Federal Government Relations, Genevieve Thompson, our Manager of State and Grassroots Advocacy, and Kayla McEwen, our Manager of Public Policy. And Kayla would be remiss if I did not mention she has the distinction of being the first ever federal lobbyist with Down syndrome. So without further ado, we can get into today's topic covering federal Medicaid changes that were signed into law this year. So wanted to start off with just a little bit of background on the Medicaid program itself. I know even among people who have been in DC a while in policy space, there can be confusion about Medicaid. It's a complicated and complex program. One of the reasons is when we talk about something like Medicare, which is primarily intended to cover adults over 65 and some individuals with disabilities, that's a federally run, federally funded program. Medicaid is this interesting hybrid. It's a joint federal and state program that provides free or low cost health insurance to eligible individuals. The way that federal state dynamic works in practice can get complicated, but it has really important implications for what we'll be talking about today and some of the new changes to Medicaid. But essentially, Medicaid is jointly financed by both the federal and state governments. So each state is responsible for putting up some of the cost of their Medicaid program, which is run at the state level in accordance with federal rules. And then the federal government contributes matching federal dollars to cover the rest of the cost of those programs. Each state, as I mentioned, administers its own Medicaid program. They can go by different names in different states, but we're still talking about Medicaid. Texas keeps it simple, usually just referred to as Texas Medicaid. Um, Important to note here that Medicaid nationwide is a major source of health coverage for individuals with Down syndrome. Um, and its importance there is limited or not limited just to medical coverage. So talking about, going to the doctor or hospital visits, but extends to home and community-based services or HCBS. Sometimes this goes by home care. It falls under a broader bucket of long-term care or long-term services and supports. But when we talk about HCBS, usually people are talking about those set of services that are delivered under Medicaid because Medicaid for everyone across the nation is the predominant payer of home and community-based services. These are largely not covered by private health insurance. There's some limited coverage in Medicare, but really we're talking about Medicaid as being the biggest payer of HCBS. So when we talk about HCBS, these cover a range of different services, but all designed to help individuals over 65, individuals with disabilities to live independently in their homes and communities rather than requiring institutional care. So this can cover things like supported employment, which is assistance to help people get jobs, to find jobs, job training they need to help them maintain paid employment. Covers case management, which would help someone develop a comprehensive, individualized support plans for these sorts of services. Can include things like home delivered meals for people who need help with that. Non-medical transportation. So medical transportation would cover hospital or doctor's visits. Non-medical transportation might be helping with public transit, but also private transportation to access these services. We talked about personal care, which is sometimes referred to as home care, but helping with activities of daily living. And then caregiver support. And this would be more for those who are caring for a person with disability, respite services, other services they need to fulfill their role. And as we get into some of the changes today, especially around state funding, really important to know that Medicaid HCBS is optional, meaning that states do not have to cover HCBS. So one thing we say a lot is that while HCBS is optional for states to cover, for many individuals with disabilities, these are essential services. And that gap makes this a tricky area when we talk about changing the program or cutting funding from Medicaid, because so many individuals do rely on these services. Now, important to mention, every state does cover HCBS to some extent, and this can be through their officially approved state plans with the federal government or more commonly through what are called waiver programs. Texas has a number of different waiver programs that provide some level of HCBS. They target different populations. There are different eligibility rules. But it's very common across the country to have, say, a waiver program that provides HCBS just for the IDD community. Sometimes they may look at individuals with blindness or just elderly individuals. But states often do provide these services through what are called these waivers. There is limited funding available for these. States have to request approval from the federal government, but also come up with a plan to actually fund these. And because this is an optional service, we see wide variation, not only in the services provided, but also the type of payments that are given to providers and the number of slots that are open in these waiver programs. So across the country, most states have quite long waiting lists for these services. So uh, individuals run into this situation where they're technically eligible to receive HCBS, but the state has a long wait list. And so they cannot receive these services, or at least not right away. Unfortunately, there are individuals who have been on wait lists for years and years. So oftentimes you'll see advice given, say, to parents of a child with Down syndrome to get on those wait lists as soon as you can, because very well can be on these wait lists for a long time. Texas is one of those states where there is quite a long wait list for services, despite having a number of these different waiver programs. And getting back to this notion that HCBS is optional for states, that raises the risk that when state budgets are tight and Medicaid gets scaled back, HCBS is one of those areas that gets targeted for cuts for getting scaled back. We saw this not in reaction to legislation, but after the 2008, the Great Recession, a lot of states had budget shortfalls, and one of the ways they addressed that was by cutting HCBS. And then finally, one last piece just to cover on the background of Medicaid is the Medicaid expansion. So this goes back to the passage of the Affordable Care Act in 2010, which allowed states to expand Medicaid coverage to nearly all adults with incomes up to 138% of the federal poverty level. So this would include adults who don't fall under the quote unquote traditional coverage categories in Medicaid, which would be low-income adults with dependents, people with disabilities, pregnant women. In exchange for states that did expand, they receive a higher federal match to cover this specific population, sometimes called the expansion population. So to date, 41 states and the District of Columbia have expanded their Medicaid programs to cover this population. Texas is one of the 10 states that have not expanded. And that will be important as we get into some of these changes because they affect expansion and non-expansion states differently. Would also mention here, most individuals with Down syndrome who are on Medicaid qualify through that traditional pathway. So having a disability, not falling within this expansion population. So we can move on to the One Big Beautiful Bill Act. If I call it the act or the law or the OBBBA, I struggle with that one. There are a lot of B's, but I'm talking about the same thing here. So the One Big Beautiful Bill was drafted and passed earlier this year. Congress spent several months working on developing it, was eventually known as the One Big Beautiful Bill, passed Congress late June, and then was signed into law on July 4th by President Trump. What's unique about this bill versus most bills that move through Congress is this was passed using the budget reconciliation process, which is a special process that allows the Senate to pass certain tax and spending legislation with just a simple majority. So as some of you may know, this avoids the 60 vote threshold, which you typically need to move something through the Senate. So prior administrations, prior Congresses have used budget reconciliation as an option to move policies forward because you only need that simple majority in the Senate versus that 60 vote threshold. Like other reconciliation bills as well, this one was included a wide range of policies. So not just Medicaid, but other healthcare provisions, Medicare, but also outside of healthcare, tax provisions, border security, military, education, a whole bunch of things were crammed in there. Some of them which cost money, some of them which save money. As the lawmakers looked to offset some of the spending in that bill, Medicaid became a target to help offset those. So looking for savings by reducing federal spending on the Medicaid program. Altogether, the changes to Medicaid, even beyond those that we'll talk about today, add up to about 900 billion in savings, meaning a reduction in 900 billion in federal spending on Medicaid over the next decade. So this is one of the most consequential pieces of legislation we've seen in terms of Medicaid in the past several decades. At a high level, and we'll go into more details, the changes that are most concerning from our perspective as we think about the impact on the Down syndrome community, on the disability community, have to do with those limits on state financing. So how the states are able to finance their Medicaid programs. Has to do with Medicaid work requirements that will be nationwide required for the first time, and then a reduction in retroactive Medicaid coverage, which we'll explain further. And then, well, some of these changes that are in the bill and some of the changes we'll talk about today take effect immediately. Others will be implemented in later years or phased in over several years. And of course, because Medicaid is this unique federal and state program, the actual effects of implementation may look different depending on what state you're in, may look different depending on whether you're in an expansion state or a non-expansion state. And one of the reasons why, we are going to continue to be involved and encourage others to monitor these changes because they're going to play out differently depending on where you are in the country. So jumping in, the first major change I want to talk about today is the new limits on state-directed payments and provider taxes. And I'm going to throw a lot of jargon at you, but stick with me here. So states have commonly used healthcare-related taxes, so actually putting taxes directly on healthcare providers in the state as a way to generate revenue to fund part of the Medicaid cost in that state. Um, these have been used for the past several decades. Almost every state has at least one provider tax, including Texas. Texas has several of these provider tax arrangements. Um, Over the past several decades, states have relied on them more and more to help finance their Medicaid programs. In addition to raising money for those state costs, it also enables, again, those matching federal dollars to flow. So already there are some existing limits on how big these tax arrangements can be because the federal government wants to limit how many federal dollars are going out the door. This bill adds in new limits on provider taxes and then also on what are called state-directed payments or SDPs. Um, these are a way for states with managed care like Texas to target specific payments. Say if they want to boost payments to nursing homes or children's hospitals, state-directed payments allow them to target a rate increase, say just for that sector or for HCBS providers. That's an option too. Um, the OBBA, the limits here include limits on new or increased provider taxes and then prohibitions on increased state-directed payments, and that is across all states. Getting in here to the differences between the expansion and non-expansion state, there are more onerous reductions in current provider taxes for the Medicaid expansion states that will take effect in later years. But for non-expansion states like Texas, those existing provider taxes are basically going to be grandfathered in. So when we think about the impacts of these limits on state financing tools like provider taxes, obviously this is going to make it harder for states to come up with their cost of their Medicaid program. States have relied on these provider taxes, some of them more, some of them less. But when states are faced with Medicaid budget shortfalls, as we mentioned before, HCBS is that area that is often hit first to be cut, to be scaled back. Rates are reduced to providers, which means that threatens the workforce available to provide services to people. As we saw after the Great Recession, when HCBS was scaled back, we saw reduced access to care, even longer wait lists for these services, which means fewer options for people to stay at home and receive the care they need. We don't know exactly how each state will be impacted, in part because states will have to respond through legislation, through budget changes. They'll have to see maybe if there are other tax arrangements they can use to raise revenue. Um, and then as a non-expansion state, Texas itself will not be subject to the phased-in reductions that are going to start in 2027, but it will be subject to the other limits on provider taxes and state-directed payments. That's primarily going to affect, plans to introduce new arrangements or to increase existing ones. Like I mentioned, the most onerous cuts here, the phase down of the provider taxes for expansion states will begin in October 2027. The next big change I wanted to talk about, and this is one that I think generated a lot of headlines and is one of the bigger savers in the bill, is Medicaid work requirements. This is not a new concept for Medicaid. There are several states that have introduced or experimented or had plans to introduce work requirements in Medicaid for certain populations. What makes the big beautiful bill unprecedented here is this will be the first time that they'll be required nationally. So the federal government is directing every state to implement work requirements. But crucially here, again, this is just for Medicaid expansion recipients. So those in that expansion population will be required to work, volunteer, or participate in an educational program for at least 20 hours per week. And so the law refers to this as community engagement versus work requirements because it includes these other areas. The impact is going to vary by state, not least because each state has to implement its own system. This is not something that the federal government is going to set up for states. They will have to set up their own platforms, their administrative capacities, the systems for checking data and exemptions. That's going to be state by state with some federal guidelines around that. It's also not clear how a non-expansion state like Texas will be impacted, or how much it will be impacted, because again, the individuals who would fall within that population, that expansion population, is pretty small because Texas did not expand Medicaid. That said, I think regardless, nationwide, most states have expanded Medicaid. Um, and as those systems get up and running, the concern here is less about that individuals with Down syndrome or other disabilities will be, necessarily applied or necessarily be subject to these work requirements, but more so concerned about bureaucratic errors, paperwork issues that cause people who should be eligible for an exemption to lose coverage. And this is something we have seen in other states that have adopted work requirements or tried work requirements. These are very administratively complex systems to get up and running. They can be prone to errors. People may not realize all the documentation they need to submit in order to qualify for an exemption. Sometimes paperwork just gets lost, and people who should be able to continue receiving coverage lose it. So we don't want a scenario where individuals are inappropriately denied an exemption solely due to a bureaucratic error or paperwork error. And on the other side, we don't want people to be confused about these requirements and feel like they have to work when they would qualify for an exemption or they already do. So that's one of the reasons we will be watching closely the implementation of these work requirements across the country. Thinking about the timeline here, uh, states are required to have their systems up and running by January 1st, 2027. That's actually a very short window for how complex these work requirements can be. Next year, HHS will put out a regulation that provides some more guidance to states on what they can and should do around these work requirements. But all in all, this is not a lot of time. It's possible that states could ask for extensions, but the law also allows some states to go earlier if they wanted to. So states could, if they wanted to, set up work requirements now. I think it's probably too early for any state to have that up and running yet. But to the point about this being a state by state process, the implementation is going to look different and could proceed on different timelines. And then the last major change I wanted to touch on today is the bill's adjustment to retroactive coverage. So a few words on what this means. Generally, states right now provide retroactive Medicaid coverage for up to 90 days prior to the date that an individual actually applies for coverage. So if I was eligible for Medicaid and I met all the financial requirements this year throughout January, February, and March, but I didn't actually put in an application until near the end of that period, Medicaid would still cover any costs I incurred during those months as long as I would have been eligible. So this coverage is important because people typically they can't instantaneously apply for programs like Medicaid the moment they become eligible, which could be the result of an emergency or sudden illness or a new diagnosis. And then when we talk about the Down syndrome community, we know individuals with Down syndrome can face unexpected healthcare needs at birth. The application process for Medicaid can be lengthy and challenging depending on what state you're in, their documentation requirements. And so the existing coverage period of 90 days allows people a decent window, a little bit of a cushion where they have some time to deal with, say, a sudden diagnosis or a health crisis before having to have that Medicaid application all completed and sent out. The OBBBA does not eliminate retroactive coverage, but it is reducing that look back period from 90 days to 60 days for traditional Medicaid enrollees, which is going to include individuals with Down syndrome in most cases, and then 30 days for expansion population enrollees. And our concern here is, of course, that when you have that shorter coverage period for retroactive coverage, that puts more pressure on individuals, on families during very stressful periods, raises the risk that someone might be stuck with really high out-of-pocket expenses that they're not able to get covered. And this change in policy will take effect 2027. So just summing up some of the key dates we're watching for implementation of these changes. Back to the limits on the new or increased provider taxes and state-directed payments. So those took effect immediately when the law was enacted on July 4th. Next year, June 2026, is when the U.S. Department of Health and Human Services will issue its final rule on work requirements. So if you're doing the math, that only leaves about 6 months before states have to have those work requirement systems up and running. And then also on that January 1st, 2027 is when that limit on retroactive Medicaid coverage will take effect. Those phase down of provider taxes in the expansion states will start in 2027. And then the cuts will increase in 2028, 2029, 30, and years after. So where we are now, these big changes have obviously been signed into law, and we at NDSS will continue to advocate around rolling back some of these changes. But there's also existing advocacy opportunities because we know Medicaid is such a lifeline for the Down syndrome community, for the broader disability community. So to give an explanation of NDSS and our policy position on Medicaid, we recognize Medicaid is not a perfect program, and many people are not well served by their existing coverage. This is a well-known issue, but we know it is such a lifeline that we want to protect, strengthen, and expand that program so it serves even better people with Down syndrome. And we oppose and have opposed attempts to weaken Medicaid or impose additional barriers to coverage and service delivery. And that has been our guiding thread as we've examined the One Big Beautiful Bill Act and as we engaged earlier this year as the bill was being developed. Across these areas, NDSS is and will advocate for a rollback of the provider tax limits. We know that this is going to have a big impact on state financing of Medicaid. And again, we know from a historical example that HCBS will be among the first areas cut if states are making cuts. Part of that is also going to be advocacy at the state level because these decisions will be made by governors, by state lawmakers around the type of services that are provided, how generous those services are, the rates that are promised to providers. Those will be made at the state level. And so advocacy at the federal and state level need to work together to protect HCBS. On work requirements, as I mentioned, these are complicated rules. These are challenging systems for states to set up. So one thing is, of course, we will be monitoring that state implementation to make sure coverage is protected for the Down syndrome community, but also looking at the resources we can develop to help individuals and families navigate new requirements so they understand who will be subject to the requirements, how to navigate them, how to apply for an exemption if needed, but also if there are opportunities or the need to appeal a decision where someone is inappropriately denied coverage. And then, of course, on retroactive coverage, we advocated against the shrinking of that look back period, but also continue to support policies where families are receiving updated information about benefits and services when receiving a Down syndrome diagnosis, and that includes information on Medicaid enrollment. This is especially important if families are going to face a shortened window in which they can apply for Medicaid and receive that retroactive coverage. And then wanted to mention some tools and resources, both that we have and that others can access as we think about opportunities for advocacy around Medicaid now and in future years. So we've mentioned some of the changes at the federal level, also being implemented across the state level. So if you go to our website, NDSS, we have resources explaining the changes that are in the One Big Beautiful Bill Act, but also some of that Medicaid 101, helping understand what the program is, why it's important to the Down syndrome community. We have testimonials. We've got great stories from community advocates about the importance of Medicaid and HCBS and are continuing to build out those resources. We also have more state focus, state advocacy focused materials that are in the works on Medicaid. Again, trying to get at this issue of HCBS and explain to policymakers who may not be super aware of how important they are to the disability community, why these should be preserved and expanded, particularly in this moment where states are going to face these budget shortfalls. This is information that needs to get out there. We want to help advocates promote and educate the importance of HCBS. We'll also put in a plug here for our DS Ambassador program, which my colleague Genevieve and Kayla manage. This is our wonderful grassroots program that enables people to meet on a regular basis for training, for dissemination of resources, being able to connect with other advocates in your community, in your state, and across the country to learn more about policy and advocacy opportunities to be if exercise effective leadership and advocacy in your area. And of course, when we talk about um, advocacy, most people have in mind, meeting with lawmakers, which is great, and we encourage that to email your congressman, your congresswoman, your senators, to give them a call. But of course, advocacy extends just beyond direct meetings with policymakers, whether at the federal and state level. It's not just about going to Washington, D.C. or going to Austin. It's about sharing your story. And this is something that's really, really important that we tell people all the time is congressmen, they hear from people like me all the time, being in the policy space for a while. But it's that personal connection, sharing your personal experience with Medicaid, but even outside of healthcare, with education or workforce issues. Those really have the ability to sway people and to influence decision making, and not just on the Hill, but sharing those stories within your local community on social media, with your neighbors, with your doctors. It's really important about building that awareness of things like Medicaid and healthcare, but also changing public perceptions about the community and about the work that people are doing. And of course, I would encourage people to stay connected locally. Um, Down Syndrome Partnership, for example, to local and state groups. As we mentioned, like so much of these changes at the federal level will be implemented state by state. And so staying connected on the state level can be the best way to be aware of some of those changes. And I just wanted to mention, as I wrap up here, we have some great community stories on our website of people and their experience with Medicaid. So I've got several here from adults with Down syndrome who have talked about Medicaid, some of the waiver programs which are helpful to them. You can see more on our website, but these ones really impacted me when I was reading through. So Nicole here, an adult woman with Down syndrome, talking about the importance of North Carolina's HCBS waiver, giving her a chance at independence, and mentions here Hurricane Helene. Um, these are, natural disasters, which create even more demand for services. But even around that, we know there are wait lists, long wait lists in North Carolina and so many other states. So this is not the time to be cutting HCBS. This is the time to be protecting and expanding those services. Sean here, this is not me, this is different Sean. Um, Here talking about his Medicaid waiver services, how they help him live independently, getting to work, um, being able to get groceries, to help with those activities of daily living. Really important for Sean, who wants to live independently. And then Kayla here, this is Kayla McEwen on our team. She lives in her own apartment. Uh, as I mentioned, she is the first registered lobbyist with Down syndrome. And for her, Medicaid means she can do all this. She can have a career, she can live by herself because of the services and supports she receives from Medicaid. So in the same vein of advocacy, wanted to mention now that registration is open for our annual Down Syndrome Advocacy Conference in Washington, D.C. We would love a strong showing from Texas, and many Texans we'd love to welcome there. Next year, it'll be May 11th through 13th, 2026. And keep an eye out. We will be opening early bird pricing is open now, and then we'll be opening up scholarships soon that help people attend. And that's the end of my slide deck. I'm happy to take a couple questions if there are any, but thank you all for listening. I really appreciate this opportunity.